Okay, so this is the case one that a G3P2 with 10 weeks pregnancy comes to gynae OPD with complaints of regression of signs and symptoms of pregnancy, and ultrasound report shows 10 weeks pregnancy with absent fetal heart sound. So the diagnosis is that it is missed abortion, as there are absent fetal heart sound and regression of the signs and symptoms of pregnancy. Then what are the two complications? So the main complications of abortion are sepsis and DIC, which is hypovolemia and shock. And then what are the besides baseline investigations bedside, what specific investigations are required in this condition? So coagulation profile is done, as there is the risk of DIC. PT and APTT is done because of the DIC risk. Then briefly describe the treatment options available for these patients. So these are induction with cytotec is done, which is followed by evacuation and curettage, and cytotec will cause the cervical ripening. The loading dose is 200 microgram, 4 tablets, followed by repeated dose after 3 hours, and evacuate the next day under general anesthesia. Okay, if the abortion occurs, so first cytotec tablets are given, and after that induction, evacuation and curettage is done under general anesthesia. Now the second scenario is that there is a 60 years old para 10 presents to OPD with complaints of pressure perineum. Para 10 means she is having a lot of kids or pregnancies, stress incontinence, and something coming out of the vagina. So what are the differential diagnoses? These are Gardner cyst, okay, urethral diverticulum, and periurethral cyst, hypertrophic cyst, cervical and endometrial polyps, and vulval tumors. These are the differential diagnoses. And UV prolapse. So it may be prolapse, it may be cysts, Gardner cyst, urethral diverticulum cyst, periurethral cyst, hypertrophic cyst, and cervical and endometrial polyps, and vulvar tumors. Okay, polyps, tumors, and cyst, and UV prolapse. These are the differential diagnoses. Now define the third degree UV prolapse. So it is the prolapse where whole uterus slides outside the introitus, called procedentia. Third degree UV prolapse is also known as procedentia. Now, what is the main support of the uterus preventing prolapse? So the main support of the uterus are pelvic ligaments, levator ani, and coccygeus. You should remember this by PLC. Okay, pelvic ligaments, levator ani, and coccygeus. Pelvic ligaments, levator ani, and coccygeus. What are the different management options for these patients? So these are, first of all, investigations is done, which is clinical diagnosis. Then routine investigations are done. Then ultrasound is done to exclude the fibroids, the ovarian cyst, the ascites. The MRI is done for suspected anatomical defects, RFT, sonography, and intravenous urogram, renal compromise, or UIT. And the treatment options are that general management is done. Then surgical is hysterectomy or vaginal repair, which is Manchester repair. This is the most appropriate treatment for the UV prolapse, that is Manchester repair. Other than these, hysterectomy also can done, and general measurements are done. Okay, so this was UV prolapse. Now the third case is that there is a G2 presents with 39 weeks gestation with the labor pains, and her BP is 140 by 100 mg, and os is 4 cm diameter. So what kind of analgesia should be given? So the analgesia that is used in this case is epidural analgesia. She is in labor and there is 4 cm dilatation, means she is in second stage of labor. And what are the complications of the analgesia? So these are dural rupture, that is accidental total spinal anesthesia, then spinal hematoma, and bladder dysfunction. This can occur due to epidural analgesia, as it is injected in the epidural area. So dural rupture can occur, spinal hematoma can occur, and bladder dysfunction can occur. Okay, now what are the complications of this analgesia? We have discussed, and what are the contraindications of it. So the contraindications are coagulation disorders, local or systemic sepsis, and hypovolemia. The fourth question is that a para 1 presents 3 days after the delivery with the fever of 101 degree Fahrenheit. So what is the diagnosis? It is puerperal pyrexia. What is the definition of puerperal pyrexia? So it is a temperature of 38 degrees C or higher on any 2 consecutive days within first 10 days postpartum after first 24 hours. What are the causes? Enumerate the causes. So these are endocarditis, UTI, respiratory tract infection, wound infection, DVT, and mastitis. These can lead to puerperal pyrexia. Now the case number 5 is that there is a primigravida present at 37 weeks pregnancy with dichorionic diamniotic twin, and both fetuses are cephalic. So what are the maternal complications of these conditions? So the maternal complications are hyperemesis gravidarum, anemia, pregnancy-induced hypertension, antepartum hemorrhage, gestational diabetes, and increased chance of operated delivery. Okay, another question in this case is that what should be the mode of delivery? So the mode of delivery is normal vaginal delivery, that is NVD. And what are the risks to the fetus during labor? So the risks are cord prolapse, malpresentation, polyhydramnios, and intrauterine growth resuscitation. Then what is the most common and serious fetal complication of this condition after delivery? So it is postpartum hemorrhage. It is twin pregnancy, so postpartum hemorrhage can occur, and the risks of the fetus are cord prolapse, malpresentation, polyhydramnios, and intrauterine growth resuscitation. Then case number 6 is that there is a G6P5 present at 35 weeks gestation to antenatal clinic. What will you check abdominally in her OBS examination? So we will check for fundal height, lie, fetal heart rate, position, and presentation. What investigations are done routinely? So these are baseline investigations, which is CBC, urinary, fetal blood, and cross-matching ultrasound. Okay, the normal fetal heart rate is 110 to 160 beats per minute. So this is antenatal checkup, and the antenatal checkup, the baseline investigations are CBC, urinary, full blood count, and cross-matching and ultrasound. And the in antenatal checkup for fetal fundal height, lie, fetal heart rate, position, and presentation is checked. Now we are having case number 7, in which there is G4P3 which presents to the labor room with labor pain. So define labor. Labor is the process of childbirth which starts with the onset of regular, painful, and ineffective uterine contractions and ends with the delivery of the baby and expulsion of the placenta. Now another question is that what is the third stage of labor? So the stage starts with the delivery of baby and ends with the delivery of the placenta. And what is the most common complication of the third stage of labor? So it is PPH. Case number 8 is that there is a G2P1 with previous normal vaginal delivery and presents at 33 weeks gestation with transverse lie in labor. So define lie. Lie is the relationship of longitudinal axis of mother to the longitudinal axis of the fetus. And what is transverse lie? So it is the fetal longitudinal axis lies perpendicular to the maternal longitudinal axis and classically present with shoulder presentation. What should be the mode of delivery? So it should be elective C-section. And what are the complications during labor? So these are fetal complications and maternal complications. The fetal complications are abnormal heart rate of the fetus, shoulder dystocia, problem with umbilical cord, and death. The maternal complications are excessive bleeding, perineal tear, obstructive labor, and dysfunctional uterine bleeding. Now case number 9. So we are having a scenario that there is a 25 years old nulliparous lady presents to the OPD with primary infertility of 4 years. Semen analysis report of husband is normal. So what is the gold standard investigation for this lady? Diagnostic laparoscopy. Okay, in case of infertility, the gold standard investigation is diagnostic laparoscopy. So 25 years old nulliparous lady presents to OPD with primary infertility of 4 years. Semen analysis report of husband is normal. Now the gold standard is diagnostic laparoscopy. Write any 2 tests to confirm ovulation in her. Ovulation is that laparoscopy on the 12th day show presence of corpus luteum and provides visual evidence of the ovulation. Okay, what are the 2 tests to confirm ovulation? So it is laparoscopy is the first test, and the second one is the progesterone levels. So at the day 21, progesterone of 28 days cycle level greater than 30 mg per ml suggests strong ovulation. Induction of ovulation. Which drug is commonly used for ovulation induction? So it is clomiphene citrate. And what are the common side effects of these drugs? So these are ovarian cancer, blurring of vision, abdominal discomfort, hyperstimulation of the ovaries. And indications are anovulations, PCOS, post amenorrhea, and infrequent ovulation. Okay, so what was in the case number 9, that what is the gold standard investigation for a lady who is infertile? So it is laparoscopy. Then what are the 2 tests to confirm the ovulation in her? So the first one is laparoscopy, in which on the 12th day will show corpus luteum, provides visual evidence of the ovulation. And on day 21, progesterone levels of 28 days cycles level greater than 30 mg per ml suggest strong ovulation. Okay, first is corpus luteum, which will be which can be seen on the 12th day. corpus luteum. And the second one is progesterone level. If progesterone is greater than 330 milligram per ml, so it confirms the it confirms that this is the case of pregnancy. Now, which drug is commonly used for ovulation induction? So this is clomiphene citrate. And what are the side effects of the clomiphene citrate? So it is ovarian cancer, blurring of vision, abdominal discomfort, hyperemesis of the ovaries, infrequent ovulation, PCOS, and post-pill amenorrhea. Now, coming towards the case number 10, in which it is mentioned that there is a G3P1 with 14 weeks pregnancy and having dermite cyst on ultrasound. So, what complications are expected? Now, there is a patient who is having dermite cyst. So, the complications are malpresentation, obstructed labor, cervical dystocia, abortion, and preterm labor, torsion, intracystic bleeding, rupture, and degeneration. These are the complications of pregnancy having dermite cyst. These are malpresentation, obstructed labor, cervical dystocia, abortion, and preterm labor, torsion, intracystic bleeding, rupture, and degeneration. Now, what are the treatment? What are the treatment of choice? So these are laparoscopic cystectomy. Okay, there is dermite cyst, so laparoscopic cystectomy should be done. If cyst ruptures, what will occur? So the complications are chemical peritonitis. If the rupture of the cyst occurs, then chemical peritonitis will occur in the abdomen. Now, what is the criteria of simple cyst? So the criteria is that unilocular size less than 7.4 centimeter and unilateral, no involvement of amentum, and no fluid in pouch of Douglas. So we have discussed the case number 9, primary infertility, and case number 10, having dermite cyst. So cystectomy is done, and rupture if occur, peritonitis will occur, and the criteria of simple cyst is that the unilocular size will be less than 7.4 and unilateral, no involvement of the amentum. Okay. Now, case number 11, there is G2P1 present at 34 weeks gestation with mild, painless, unprovoked vaginal bleeding. So, what is the diagnosis? With mild, painless, unprovoked vaginal bleeding. If bleeding occur at 34 weeks, it means that there is placenta previa. And how will you confirm your diagnosis? So it is confirmed by ultrasound, that is demonstrated abnormal location. Then what are the differential diagnosis? So these are placental abruption, vasa previa, and cervicitis. And when should she be delivered? So she should be delivered immediate delivery when pregnancy has reached term, that is 37 weeks, greater than 37 weeks, hemorrhage is profuse and life-threatening, and dead fetus or malform. If small and self-limiting, then prolonged pregnancy can occur. What should be the mode of delivery? So it should be elective C-section. Okay. When should be she delivered? She should be immediate. There should be immediate delivery when pregnancy has reached term and hemorrhage is profuse and fetus is malformed. These are the indications for the immediate delivery. Okay. Now, case number 12. So, we are having a scenario that there is a 35 years old para 2 presents with 6 centimeter simple cyst. So, write any 3 complications of the ovarian cyst. So, the complications are rupture of ovary, abscess formation, and torsion. These are the complications of the simple cyst. Then, how will you differentiate a benign from a malignant cyst? So, benign is cystic mass, malignant is partially solid and cystic mass. Then it is benign is mostly unilateral, while malignant are bilateral. Benign are freely mobile, while malignant are restricted mobility, and benign are having smooth surfaces, while malignant are having irregular surfaces. And the size of the benign is less than 8 to 10 centimeter, while the malignant is having size greater than 10 centimeter. So simply we can say that malignants are more harsh than the benign tumors. How will you manage a patient if she has simple ovarian cyst of 6 cm in the first trimester of pregnancy? So, if asymptomatic cyst, okay. So, how will you manage a patient if she is? What's wrong with it? So, how will you manage a patient if she has simple ovarian cyst of 6 cm in the first trimester? So if asymptomatic cyst, wait till until 14 weeks of gestation. This avoids risk of removing corpus luteal cyst upon which pregnancy might be dependent. With symptomatic cyst upon can undergo with symptomatic cyst can undergo immediate laparoscopy or laparotomy covered by tocolytic drugs to reduce the initiation of labor. Okay, this was case number 12. Now coming towards case number 13, in which the question is that there is a primigravida present at 33 weeks of gestation, and with abdominal pain of spasmodic type. So what are the differential diagnoses? So if she is having abdominal pain, so it might be ectopic pregnancy, appendicitis, uterine adhesions and fibroids, as we have discussed the differential diagnosis of fibroids in the start of the video. Then how will you diagnose preterm labor? So the diagnosis is abdominal pain, pelvic pressure, lower back pain, progressive cervical dilatation and vaginal discharge will be there. And what drugs should be given to such patient to stop contractions? So these are tocolytic drugs to stop contractions. And what are side effects? So these are respiratory and cardiac arrest and toxicity and defined preterm. So preterm labor is the spontaneous occurrence of regular uterine contractions, production of the cervical changes and dilatation, which is the opening of cervix after 24 weeks but before 37 weeks of gestation. A primigravida present at 33 weeks gestation with abdominal pain of spasmodic type. So these are the answers. Now question number 14 is that there is a G2P1 present at term to the labor room on examination, or is 4 cm dilated and membrane is intact. So how will you monitor the fetus during labor? So fetal heart rate, meconium aspiration and fetal scalp pH is checked for the monitoring of the fetus. Then in which stage of labor should partogram be plated? So it is plated in second stage of labor. Define the third stage of labor. So it is start at delivery and ends with the delivery of the pregnancy. And what are the most serious complications of third stage of labor? So it is PPH. So partogram plotting is started at the second stage of labor. You should remember this. And for the fetal monitoring, for fetal heart rate, meconium aspiration and fetal scalp pH is done. Now case number 15 is that there is a 20 years old girl present with weight gain, hirsutism and oligomenorrhea. So what is the diagnosis? These are polycystic ovarian syndrome. How will you confirm it? The confirmation is done by hormonal assay, that is luteinizing hormone and follicle stimulating hormone of 2:1, and elevated testosterone level, fasting insulin level increase, estradiol will be increased and sex binding globulin hormone will decrease. Now how you will confirm it? So it is confirmed through ultrasound, which is greater than or equal to 8 subcapsular follicular cyst and less than 10 centimeter diameter and ovarian stroma and thickened sclerotic capsule ovary. Now what are the long-term side effects of this disease? So these are infertility. And what is the treatment of choice? So the treatment of choice is for oligomenorrhea, and for obesity, weight loss, dietary modifications, and folic sachet is it reduce the weight, and for his hirsutism, anti-androgen for 6 to 9 months and waxing and laser. Okay. Now right to investigation for detection of ovulation. What are good standard investigations for infertility? So it is laparoscopy. And for detection of ovulation, first one is laparoscopy and the another one is progesterone levels. We have studied this. Now case number 16 years old with primary amenorrhea and cyclical abdominal pain, secondary sexual characters will develop. What is the diagnosis, specific investigation of these conditions? Okay, so this scenario is already discussed. It is same as case number 9. This is case number 9. Okay, these are the questions. So these were all the important scenarios in the field of gynecology. And okay, case number 16 is same as case number 9. And okay, this one is left 16 with primary amenorrhea and cyclical abdominal pain and secondary sexual characters. So what is the diagnosis? It is imperforate hymen, as there is primary amenorrhea. and she is adult, that is sexual characters are developed, but she is not having any period, so the diagnosis is imperforate hymen. The specific investigations for these conditions are routine investigation, which is FPS, and urine RE and FPC, and the specific are abdominal pelvic ultrasound. And the treatment is cruciate incision is done, that is 4 flaps are formed, chocolate colored fluid starts coming out, and cut the phlegm with scissors and becomes hymen. Now, what are the differential diagnoses? So these are fibroids and congenital adrenal hyperplasia, anorexia nervosa, and follicle stimulating hormone abnormality and ovarian insufficiency. These may are the differential diagnosis, or it is the cause of primary amenorrhea. So these were all the important scenarios which are important for the talks and the gynae and obs subject. Thanks for watching.